good conversations with the governor of Nebraska and the governor of Iowa here. And it's interesting that functionally, even though they have not given a strict stay-at-home, what they are doing is really functionally equivalent to that. And we had a really good conversation with both of the governors. When I had mentioned that, I think there was a public response that they weren't really doing anything at all, and they really are doing a very good job, both of them. Those are the only two that I spoke to, but it was a really good conversation, and I want to make sure people understand that just because they don't have a very strict stay-at-home order, they have in place a lot of things that are totally compatible with what everyone else is doing.
If I can ask a question, Dr. Fauci, before you.
Go ahead.
About getting back to normal, you said you wanted to get back to normal as soon as possible. Will we truly get back to normal in this country before there's an actual vaccine that's available to everybody? How do you start lifting the restrictions safely?
Yeah, well, John, if back to normal means acting like there never was a coronavirus problem, I don't think that's going to happen until we do have a situation where you can completely protect the population. But when we say getting back to normal, we mean something very different from what we're going through right now. Because right now we are in a very intense mitigation. When we get back to normal, we will go back gradually to the point where we can function as a society. But you're absolutely right. I mean, if you want to get to pre-coronavirus, that might not ever happen in the sense of the fact that the threat is there. But I believe with the therapies that will be coming online and with the fact that I feel confident that over a period of time we will get a good vaccine, that we will never have to get back to where we are right back now. So if that means getting back to normal, then we'll get back to normal.
I think that.
So I can talk a little bit more about testing later on, but as the president said, 1.79 million tests have been done, and this does not count the hundreds of thousands of tests that are done within hospitals that are now currently not reporting, so I'm sure we're well over 2 million. That Inspector General report was done here, 23rd, 24th, during our ramp-up period, quite a long time ago. There was clearly, and it's hard to interpret the report because it mixes up all kinds of things, but clearly there was complaints by some hospitals of a backlog, probably at send-out tests, and that is true. There were several days of backlog at some of the major labs that have been taken care of. We know now that the ACLA labs now have a 24 to 48 hour turnaround. They're doing well over 100,000 tests a day. We now have the Abbott machine that's point of care. That's 18,000 of those instruments throughout the country. The Cepheid machine is now all across the country with a 45-minute turnaround. We have worked directly with many of the hospitals that have their own laboratory-derived tests. Some of those really, quite frankly, didn't understand the regulatory freedom they have to use other different kinds of instruments or different kinds of reagents. So, like they do now, and I'm on the phone with them all the time to make sure that everything is clear. We have a 24-hour call number. But that's what it was there for. And I don't know the Inspector General. I don't know that person. I tell you one thing I have a problem with. If there was such a problem that she knew about or he knew about on March 23rd and 24th, why did I find out about the tests from them on the news media at 8 o'clock this morning? If there was a problem, I think you're ethically obliged to tell me where that is so we can interact with it like I do every single day. But that's a discussion for the future. I think testing is really in a good position right now, and I'd be happy to expand on some of the really good tests that are coming up. I'm not going to tell you how many are in the stockpile, but I can tell you that we look at ventilator use granularly every single day in every single state and down to the hospital level. So we have been able to meet and easily meet all the ventilator requirements that have been brought to us by the state. No one has not gotten a ventilator that needs a ventilator. And as far as we can project, looking at all models, every person who needs a ventilator will get a ventilator. I'm a ventilator doc, right? I'm an ICU physician for children. Spent every day of my life managing people on ventilators. This is my community. It's also the Surgeon General's community as an anesthesiologist. So what we have in the stockpile, I think, is not a number that we give out, but we have thousands remaining in the stockpile. And now you're seeing out of the appropriate American spirit that when a state like Washington or California doesn't need that ventilator, they're doing the right thing by moving them around the country.
On Saturday, it sounded like you said that for the next week, people in high-risk areas should not even go to the market or the drugstore. Is that what you meant to say, or is that accurate?
You know, out of respect for every single healthcare worker that's on the front line, whether they're a nurse, a doctor, a respiratory therapist, the phlebotomist, the persons who come in the rooms to clean, you know, out of respect for them, we as Americans should be doing everything possible. And what I meant was, if you can consolidate, if you can send one person, the entire family doesn't need to go out on these occasions. We really need, this is a highly transmittable virus. We've been saying that we want every American to know that what they're doing is making a difference, but we need to have solidarity of commitment from everyone to really, so, you know, maybe once every 2 weeks, we can do a grocery store and pharmacy shop for the entire family. So it was really about, we have to do everything we can. I know I see on the TV stations the level of human suffering in the hospitals. Dr. Fauci and I and Admiral Giroir have spent our lives taking care of others. We need to take care of each other now as Americans and do everything that's in those guidelines. And I know they're tough. I know incredibly how tough they are. My grandchild of 10 months got a fever of 105 this weekend. I'm the doctor, and I couldn't get there. I mean, so I'm trying to explain to my daughter how to listen to her lungs, how to listen to her lungs,
So you
and then
did
the
not
baby's
get there.
lungs.
You did not get there?
I did not go there.
Good, I'm very happy with that.
Because of you two. I mean, when you can't take that kind of risk with the leaders of the country. But, you know, we're all, and that's just an illustration that I know you all are making sacrifices, and I guess I want everyone to take this seriously. So that was really a call of seriousness of how important this is and how we're starting to see the impact, but you can see what can happen when you come at this a little bit too late. And that's why the message, before you see it, before you have to see your hospitals and your emergency rooms overwhelmed, it is on us as a member of this community, of this country, to do everything possible to save one another. And so that was really what I was saying, and I will continue to say that, because I do believe it's making a difference. You can start to see it making a difference, but we have to do even more right now, because that will predict where we are 2 or 3 weeks from now.
So let me clarify, and I know you probably understand this, is the antibody test does not tell you if you have the active virus in your nose. If you're positive for the antibody, it strongly implies, it means that you have had the virus before. And to the degree that we know of medical knowledge, you will probably, highly probably, be protected against getting the virus again in the future. So I want to make something clear. There's no antibody test approved, okay? Approved is not a word we talk about. There is a test or two that has received emergency use authorization, and many, many, many others out there that have not gone that way yet. And I want to take this opportunity to caution. There is a very consolidated effort between the FDA, CDC, NIH to validate some of the tests that are on the market right now, because it is very important that they actually do what they say they do. And we have reason to believe that not all of them are going to perform well. I don't know the primary source, but the Financial Times just reported that the UK had 17.5 million antibody tests that they bought, and none of them work. So we're not going to get in that situation. We're going to be very careful to make sure that when we tell you you're likely immune from the disease, you're really, that test really said that. Now, I will also make a statement, and there's a lot of work on here, and I'm very excited about it. As opposed to the test for a novel virus, the antibody type tests are very sophisticated technology, but they're old technology. This we expect to have many tens of millions of tests the first month that we are really sure that the test makes sense. So this allows for surveillance screening, and Dr. Birx is one of the world experts to understand is 1%, 5%, 20% of Americans have been infected. But it also allows us to have very widespread, tens and tens of millions of people screened with a finger prick on the spot.
By when, just to be, by May, you're saying this will happen? Or
So,
when?
so science doesn't run on rails, right? So we need to make sure that the FDA, the NIH, which they're actively doing right now, assure that the test that they're testing really do perform the way they should. And if things work out the way we believe they will, we will have millions on the market by May in a sophisticated way, in a prospective way, that we get the surveillance we need. We can test people to see if they've been exposed, immune, and go back to work. And a combination of that kind of test with the current kind of test we have now is how America opens back up
And how
again.
will you prioritize who gets those tests? I mean, tens of million, we're a country of 300 million. How do you determine who you're going to have that test?
Well, we are having active discussions under the leadership of Dr. Birx and the task force, but you can imagine how that is, right? But with tens and tens and tens of millions of tests per month that are available, you could really do very widespread testing. But let me just give you an example. I'll just give you one example. It would be very important to know if the virus is still circulating here, whether, for example, a healthcare worker or a long-term care nursing home worker is immune from the virus and can't carry it. Very, very important to protect our elderly in that situation. But also, if you haven't been exposed, to make sure that you really take precautions and maybe take care of the people who don't have the virus and you don't have the virus. So it's complex, but it's not complicated on how you go about looking this in different segments of society. And I don't want to take too much more time at the podium, but antibody tests are a different thing. They're coming. We're highly confident that this can be scaled very rapidly and provide us a bit of information we just don't have now.
Thank you, Mr. Vice President. I think you heard very clearly our concern in the New York, New Jersey metro areas. This also includes Connecticut and Long Island. As we talked about, we did see a significant increase in Sussex County over the weekend. The weekend numbers are always difficult. I want to be clear on that because sometimes case reporting is not as accurate over the weekend. So we'll be watching very closely today's numbers and Tuesday's numbers. We're also very course focused on the New Orleans metro area, and that includes the 3 parishes of Jefferson, St. John's the Baptist, and New Orleans proper, and of course the Detroit area, which is Oakland and Wayne. As we mentioned before, we're continuing to track very closely out of concerns of it potentially reaching logarithmic phase in the Chicago metro area, the Boston metro area, the DC and Baltimore metro area, Indianapolis, the Denver area, and 2 regions of Pennsylvania, Philadelphia, and the Pittsburgh area, as well as Dallas and Houston in the Texas area. I had a very encouraging call because we also don't want to miss anything. Remember, I showed you a lot of states were very much under 25 and 50 cases per 100,000. There were a few standouts that we were concerned about, which was Vermont, New Hampshire, Idaho, and Montana. We had excellent calls today with their health commissioners, and they're they're on top of the situation. These were micro outbreaks that occurred due to ski events and weddings and nursing homes, and they were able to describe in critical detail the incidents and how they're tracking and tracing. So they are still doing full contact tracing through those areas, and I just want to applaud both a rural and metro problem, and I really want to applaud how many of the states that may have smaller populations are approaching this. That gives us encouragement of how we can talk about beginning surveillance activities at the same time we're following these very clear outbreaks and ensuring that there's full supplies based on the very granular data that we're utilizing. And I just want to thank the mayors and governors who get us that granular data and allows us to make these deep interpretations across all of the United States. We know each governor is concerned about their areas, but these metro areas cover different areas. So the Philadelphia area also includes southern New Jersey and Delaware, and so we have to really look at things very much as both the metro and the communities that surround those metros. And so all of those people, we ask you again throughout the United States to follow these very clear guidance. I want to just recognize both HHS, and you heard about the work that Admiral Giroir is doing, the work that Dr. Hahn and Administrator Seema Verma are doing, and also Administrator Engels in the work of HRSA to really ensure that our federally funded clinics are actively engaged in all of these aspects. But I also want to recognize the military, the medical corps, the nursing corps, and the medical subspecialty corps. These were my brothers and sisters for 29 years. It is highly unusual for the active force to be called into a domestic situation. I think that shows you how seriously we're taking this at the federal government level. In my 29 years in the military, I was never deployed domestically. So this is showing you how serious of an event we take this. If the military is deploying domestically, it is another reason for every American to be following these guidelines. Finally, CDC quietly launched a new website. It's, if you go to cdc.gov and you go to COVID-19, you can find their surveillance data. This surveillance data is bringing together our influenza-like illnesses with their syndromic management databases so that you can track the respiratory disease across the United States. The states are used to using this system. It's in emergency rooms, it's in hospitals, it's in doctors' offices, and it gives you insight, and you can see very clearly influenza A peak. You can see the influenza B peak, and now you can start to see the respiratory disease from this current outbreak. These are the systems that exist within the United States that will be strengthened in order for us to do comprehensive surveillance. So I just want to assure the American people, while we're working on these outbreaks, we're also working on bringing new systems together that have a comprehensive look across the country, building on the strong work of CDC as a public health institution, so that we can work county by county, community by community, state by state, to really understand where this virus is and where it will be, but also as an early alert for us in the future. So I just want to assure the American people that as we're working on the crisis of today, we're looking to the future to ensure we have the systems in place to bring those early alert systems together while we work on the antibody testing and while we work on continuing spreading and increasing the diagnostic capabilities that you see presented here. Thank you.
Okay, I just wanted to, okay, I will. It related to something I said yesterday about that somewhat paradox of everything going up at the same time that the feeding into this engine of this virus is starting to show some signs. So Governor Cuomo today reported an interesting data from New York, namely that the number of hospitalizations, the number of admissions to intensive care, and the number of requirements for intubations over the last 3 days have actually started to level off. So again, everybody who knows me knows I'm very conservative about making projections, but those are the kind of good signs that you look for. You never even begin to think about claiming victory prematurely, but that's the first thing you see when you start to see the turnaround. That doesn't mean we don't have a lot of work to do. That tells me, instead of saying, that's pretty good, it's we got there through mitigation. We cut off the stream of people who ultimately required hospitalization, required intubation, required all of the kinds of extreme methods. So we just got to realize that this is an indication, despite all the suffering and the death that has occurred, that what we have been doing has been working. So the call that I say every time I get to this podium is just keep it up, because this is going to get us out of it. This is our best and only great public health tool.
And are we starting to see that across many states? We're seeing the level of hospitalizations and deaths is lower than what we anticipated.
Well, you're going to see it most dramatically, John, in a place like New York, where you see it goes up and peak, and then it will hopefully, and I think it will, come down. When you have places like Seattle, which and Washington State, who did a really good job from the beginning, it never really did that. So they were able to keep it down. And on the charts that Dr. Berg showed, when you saw California and Washington State, they were fortunate, they did a good job, that it never really got out of hand. So again, this is a big country, and you have a number of different metropolitan areas. I think if we do it right, you're gonna see those who have not peaked will not peak, and those who have peaked, the New Orleans, the New York, New Jersey, Chicago, Detroit, and others, you're gonna see the same thing if we keep our foot on the accelerator.
Dr. Fauci? Just following up Dr. Fauci's comment earlier about what it's like going to be coming back to normal, and until there's a vaccine, that there'll be gradual steps towards restoring normalcy. Under that, short of a vaccine, does putting 80,000 people, fans, spectators in a sports stadium, or 25,000 politicos in an arena for a political convention this summer make a lot of sense? Or does those sorts of things require a vaccine to fully protect the American populace?
No, I don't think that you're going to have to say that the country cannot get back to a real degree of normalcy until you absolutely have a safe and effective vaccine. It will be really evaluating the kinds of things, and that's the reason why it was discussed up here, why it's so important to have an antibody test so you know what the penetrance is in society. And then we have a situation where we don't ever want to get to have to mitigate. We want it to be able to contain. And by the time we have to face what's going to happen with this going back to normality, we will have in place the capability of identifying, isolating, contact tracing, so that it never gets out of hand. Ultimately, the showstopper will be obviously a vaccine where you can vaccinate people and you won't have it. There's going to be another issue that's going to be important, and it has to do with somewhat of a comparison, for example, with influenza. We go through multiple cycles of influenza. There's always a degree of background immunity in the population. I mean, that will ultimately happen if we get a situation where we get back to normal. Now, I hope we don't have so many people infected that we actually have that herd immunity, but I think it would have to be different than it is right now. So again, remember when you say normalcy, I mean, we could get back normally, economically and otherwise, without necessarily saying we're going to forget about the virus. We have to pay attention to this because we've had a very bad experience with this virus.
Dr. Fauci, can I follow up on that, please? Thank you, and this is for the Vice President, for Dr. Birx and Dr. Fauci, but can you give us a sense of, and I know you don't want to make any projections, but where we are with the numbers? Because we saw that horrible number today, more than 10,000 deaths now in the U.S. Are we on track for those best-case scenario numbers that you had laid out, the 100,000? Or are we potentially coming in lower than that at this point, given some of what you're seeing?
It just gives me an opportunity to thank and respect the modelers who have really worked on this, because there's a large number of them have worked very hard and done a lot of predictions. And what we did is we did predictions of predictions. We like to integrate data, and so that's where you come up with these numbers. I think Dr. Fauci and I both strongly believe that if we work as hard as we can over the next several weeks, that we will see potential to go under the numbers that were predicted by the models. And I think that is really two things. It is the extraordinary compliance of the American people and the diligence that they have mitigated with. Because remember, we are doing this strictly by behavior change. It's very hard to change trajectory of viruses on just behavior change. We have had difficulty in our past doing that. So that's what we're doing, and that's what the American people are doing. But the other side of that is the incredible insights that Washington State and others are providing on how to better care for the patients in the hospital. And so those two pieces are coming together that could have a dramatic impact on the predictions of the mortality from this disease.
So I'm glad you asked that question, because I've said it a couple of times here. I want to say it again. Repetition is good. Is that models are good. They help us to make projections. But as you get data in, you modify your model. And I've always said, data always trumps models, always. So what I feel, and I believe that Dr. Birx also feels, that I don't think anyone has ever mitigated the way I'm seeing people mitigate right now. This has never happened in this country before. So I am optimistic, always cautiously optimistic, that if we do what I've been talking about over the past few minutes, we can make that number go down. I don't accept every day that we're going to have 100 to 200,000 deaths. I think we can really bring that down, no matter what a model says, because when the data comes in, they'll start to saying, you know, maybe you are essentially overshooting the model. And I think that's where we can go. That's the reason why I like to always get up and tell the American people, it's the virus doing what the virus wants to do, and it's we as a society doing what we can do.
More of a personal question, but Dr. Burks, can you tell us if your granddaughter's okay? And
Yeah, I'd like to know too.
Well, thank you. Due to her, the great care of my 91-year-old nurse mother and my daughter, she's down to like 100 to 99 now, but it was 3 days of 104 and 105, which is, you know, babies can do that, but it's very scary, especially when I couldn't assure myself that she was fine. So it was just some sleepless nights for me and them as they kept her fever down. So thank you for asking.
do you have the virus?
Oh,
or-
no, I'm sure it's roseola or something. They have not been out of the house. They're not allowed out of the house. They've got 2 granddaughters under 1, 2.5 almost, and 1 only 10 months, and my 91-year-old and 96-year-old. So no one is allowed in that house or out of that house because there's too much precious cargo inside the house.
How about one more question, we'll let
Thank
you
you,
all.
Mr. Vice President. For whoever wants to answer this, it's a technical question. So FEMA says that it is in the process of distributing 90% of each state's allocated supplies for the National Strategic Stockpile. And that allocation is determined based on population by the last census in each state. And the other 10%, it says, is going to frontline healthcare workers serving in the federal response efforts. So where are those healthcare workers in the federal response? And do you envision a scenario in which you could start giving states more supplies from the National Strategic Stockpile?
You know, it's a really good question. And let me say the Strategic National Stockpile, and I'm going to have Admiral Giroir speak about his piece of that, has been largely deployed. We are continuing to replenish it in part with a small portion of what's coming in from around the world. You've heard about our air bridge, now more than 50 flights that have been scheduled that are bringing millions of supplies into the United States. What we're doing is taking less than 10% of that, put it into the Strategic National Stockpile, so we have that to basically provide for states on an as-needed basis. But the other 90%, that system that I just described earlier when the president was here, is working with the 6 major medical distributors in the country to deploy those resources to New York, New Jersey, Connecticut, Louisiana, Michigan, Illinois, the exact priority that you just heard Dr. Burks describe and that the data informs. And those decisions are being made every single day. And so while if a hurricane hits Florida or tornadoes or flooding tear through the state of Indiana, we're very accustomed to FEMA coming in, drawing from the national stockpile, providing specific resources. In this case, with a nationwide effort, what President Trump directed us to do was literally marshal the resources of the full economy to be able to make sure that we can meet the needs for personal protective equipment, ventilators, and all manner of supplies. And we're doing that in a small way through the Strategic National Stockpile, but in the largest way through that control tower system that Admiral John Polovchik is running for us, that is deploying those resources and making sure they're going straight to where they need to go. And as I said earlier, those decisions are being informed by the data, and they're literally being made by our team at FEMA on a daily and sometimes hourly basis. And we'll continue to keep you informed, as we did today, about where some of those are going. But let me let Admiral Giroir finish that answer.
I don't really have much more to add to that. The Vice President is certainly well informed about that. And I want to assure you that all the sourcing around the world, if it's there, we're putting it in our supply chains. We're buying more. Manufacturers are stepping up to the plate. And this is going not just by percent allocation, but it's going to the exact places that need it in the quantities that they need to take care of patients. And we want to make sure, this is a two-way street. We get the data in from individual hospitals to know exactly what their burn rate is, exactly what they need. And we want to make sure that they feel comfortable that they're going to have supplies because they will. Because part of this is about potential shortages, some places. Most of it's about a fear of a shortage. If I'm a physician in an ICU and I'm not sure that it's going to be there, that's going to scare me. It's going to scare my nurses. So we want everyone to have that assurance that we will provide you what you need over weeks, periods of time, exactly to your need. And Admiral Polubchak and his team, and again, it's all military in there. I mean, he is the logistics guy for the Joint Chiefs of Staff, right? This is what he does. He is a wizard. There are more stars around me in the DoD part of the military than I've generally seen outside of the Pentagon. This is really being run as a military operation. I'm in the U.S. Public Health Service, so we're part of HHS. The Surgeon General and I have the honor of running that service. We are shoulder to shoulder in the field, in the military hospitals with everyone else. There are only 6,100 of us. 3,000 are doing direct patient care on a daily basis. We take care of the Indian Health Service, the Bureau of Prisons, those in detention at the border, et cetera. That's what we do. The other 3,000, over 2,000 of those are in the field already, taking care of patients directly, and we have more going out the door every day.
And if I could just follow up on that very quickly then, is it even worth then governors writing into FEMA if they've already received their 90% allocation and you're getting data directly from the hospitals to ask for more at this point?
This has been a very cooperative interaction. I bet I talk to 5 governors a day, and we talk out the issues and understand what they perceive in their state. They often help point us to particular areas that they feel need more attention or there needs more communication. So it's been very productive. I have to look up what governor goes to what state because that's not my world, but it's been a very productive interaction. So I think all of this is necessary. I'm on almost every governor's call with the vice president. They're very meaningful, they're impactful, they're informative, they're communicative. We talk to each other, but then we do get down to the individual hospital level because when the rubber meets the road, you got to know what the docs, nurses, respiratory therapists, the people who clean the rooms are an important part of the team. I want them to come to every work saying, it's not that I cleaned a room, I'm saving lives today. And they are saving lives by keeping the viruses off the surfaces and reducing transmission. So you've really got to get that granular, and we're to a point with Admiral P's. You have 2 admirals with the worst pronounced names in the world, so Admiral P, Admiral G, but Admiral P's team really has this covered down to the individual hospital level.
Thank you.